Good morning, dear students. Today we are going to discuss regarding hypertensive disorders in pregnancy, which is also known as maternal hypertensive disorders. And this is a group of high blood pressure disorders, and which is a leading cause of maternal mortality in India. Let's see the introduction. It is one of the common complications met in pregnancy. If we're saying the pregnant ladies, the most common disorders that usually seen in the pregnancy period is the hypertensive disorders, and which contribute significantly to maternal and perinatal mortality and morbidity. So it is very important to find out to treat the hypertensive disorders during the pregnancy. Coming to the classifications, the first is gestational hypertension. In gestational hypertension, there will not be proteinuria, that is the absence of protein in urine, or pathological edema. So, in most of the situations, you can see only the physiological edema during the evening time, and the mother will get relief from the edema once she will get enough rest period. So that kind of hypertension is gestational hypertension without proteinuria and pathological edema. Second is pre-eclampsia, which is little bit complicated, and it consists of hypertension, proteinuria with or without edema. So this is the triad of symptoms which you can see in pre-eclampsia. There will be hypertension that is more than 140 by 90, proteinuria, that is the presence of protein in albumin, and in some cases you can see edema in the lower extremities also. So if you see these symptoms in a mother, you can consider the mother in a pre-eclampsia group. Next is eclampsia. So it is a condition where the pre-eclampsia is complicated with fits or coma. When these triad symptoms that you have seen in the pre-eclampsia comes along with the fit, that is known as eclampsia. Next classification is chronic hypertension. So it is defined as the blood pressure exceeding 140 by 90 before pregnancy or before 20 weeks of gestation. It means when the hypertension is first identified during a woman's pregnancy and she is less than 20 weeks of gestation, we will say it as chronic hypertension. This can be due to CRF or essential hypertension. Essential hypertension means the blood pressure is increased because of any kind of cause, or you cannot find any cause behind the hypertension. That is known as essential hypertension. Next is pre-eclampsia or eclampsia superimposed on chronic hypertension. So because of chronic hypertension, the mother is later developing pre-eclampsia or eclampsia. So these are the main classification of hypertensive disorders in pregnancy. In these classification, mainly we are going to discuss regarding the pre-eclampsia and eclampsia. So in this slide, we are going to see PIH. PIH means pregnancy-induced hypertension. So it is defined as the hypertension that develops as a direct result of gravid state. So the hypertension which develops due to the state of pregnancy, that is known as pregnancy-induced hypertension. And this also includes, that is gestational hypertension, pre-eclampsia and eclampsia. Gestational hypertension means the hypertension which develops during the pregnancy stage. That is gestational hypertension. Second, pre-eclampsia, which I have previously explained. It consists of triad of symptoms like proteinuria, hypertension, and with or without edema. Eclampsia means when the pre-eclampsia is complicated with coma or fits, it is known as eclampsia. So this all comes together known as PIH or pregnancy induced hypertension. Coming to the classification of PIH, it is mainly classified into two, that is primary and secondary. Under the primary comes the pre-eclampsia and eclampsia, and in secondary there are two types. First is pre-eclampsia, eclampsia superimposed on chronic hypertension, Second, the preeclampsia or eclampsia superimposed on chronic renal disease. So these are the main two classifications of PIH, primary and secondary. Now let's see what is preeclampsia, what are the symptoms of preeclampsia, and how we can treat the preeclampsia without causing any damage to the mother as well as the baby. Moving to the definition of preeclampsia, it is a multi-system disorder of unknown etiology characterized by the development of hypertension to the extent of 140 by 90 mmHg or more with proteinuria after the 20th week of gestation in a previously normotensive and non-proteinuric patient. So it means in a preeclampsia mother, she will have the hypertension that is 140 by 90 mmHg or more, and she will experience proteinuria along with that. So if you are seeing these symptoms, that is known as preeclampsia. Let's see the diagnostic criteria of preeclampsia. As you all know, the first diagnostic criteria is hypertension. There will be the rise of BP, that is 140 by 90 mmHg, and you also need to calculate the mean arterial pressure, that is MAP. There is one formula for that, that is systolic pressure plus diastolic pressure into 2 by 3. You can use this a formula for calculating the MAP, and if it is more than 105 mmHg, you can say the mother is hypertensive, and you need to measure the BP at least 2 times in a mother per day with a 6 hours gap. And you should remember that while you are checking the BP, you should always use the right arm for the mother. In both cases or the 2 times while you are measuring, you should take the BP from the same arm. The second diagnostic criteria is edema, and you can see the pitting edema over the angles after 12 hours of bed rest also. So this edema is a swelling in the body caused by the excess fluid, and it often you can see in the legs, feet and ankles. If you press on a swollen area and the pit still remains, that is known as pitting edema. So in preeclampsia patients, you can see the pitting edema. So there will be rapid gain in the body weight. But if the edema is physiological, that is normal. But in this case of preeclampsia, you can see the pathological edema. The third one is proteinuria. The term is same as albuminuria. It is the protein leak out into the urine. That is known as proteinuria or albuminuria. The presence of total protein in 24 hours is more than 0.3 gram on at least 2 random samples. That is proteinuria. So the protein rate is more than 0.3 gram in 24 hours of urine. This is the classification of proteinuria. You can say it as trace if the protein is 0.1 gram per liter in the urine, and if it's 0.3 gram per liter, that is plus 1. 1 gram per liter, that is 2 plus, and 3 plus 1, that is 3 gram per liter, and we will consider it as 4 plus when there is 10 gram per liter of protein in 24 hours of urine. Coming to the risk factors of preeclampsia, first is primary gravidity. If the mother is very young or if the mother is very elderly, there is more chance of the mother to get the preeclampsia. Second, family history. If she having any history of hypertension, preeclampsia or eclampsia in the family, there is 50% of chances for the mother to get the same symptoms in the present pregnancy. Third is the placental abnormalities like poor placentation, hyperplacentosis, that means excessive exposure to the chorionic villi, and placental ischemia, that means there is decreased blood supply, and because of that there is dead tissues in the placenta, that is known as placental ischemia. And the last is the monad pregnancy. So these are some placental abnormalities which can cause the increased blood pressure and preeclampsia. There are some more risk factors such as genetic disorders, immunological phenomenon, and pre-existing vascular or renal disorders. Let's see the clinical types. It is mainly classified into two, that is mild and severe. Mild if there is sustained rise of BP more than 140/90 but less than 160 systolic or 110 diastolic, and you cannot see or there is without any significant proteinuria. That is mild case. So the BP is more than 140/90 but less than 160/90 and there will not be any proteinuria. That is considered as mild. And in severe case, there is persistent systolic BP of more than or equal to 160 mmHg or diastolic of more than or equal to 110 mmHg. So the BP is more than 160/110 and there will be persistent severe epigastric pain for the mother. The other symptoms that you can see in the severe type is cerebral or visual disturbance. As there is increased BP, the mother will have visual disturbance and oliguria will be present. That is, the urine output in 24 hours will be less than 400 ml. The protein excretion in urine may be more than 5 gram per day. And if you see the blood values of the platelet count, it will be less than 1 lakh. And the most serious complication of high blood pressure during the pregnancy is the HELP syndrome that you all know, that is hemolysis, elevated liver enzymes and low platelet count, which can be seen as a serious complication of high blood pressure during pregnancy. Next is retinal hemorrhage due to the damage of the blood vessels in the eye. As there is increased blood pressure, it can also affect the baby in the mother's womb, which can cause to IUGR. And finally, the pulmonary edema due to the edema in the lungs or the fluid accumulation in the lungs, which can lead to the pulmonary edema. So these symptoms you can see in case of severe case. Next are the clinical features, and in this we are seeing the mild symptoms, alarming symptoms and some of the signs of preeclampsia. This preeclampsia frequently occurs in the primary gravida mothers. If you're seeing the multi and primary gravida, about 70% of the mothers, primary gravida mothers having the preeclampsia when compared with the multi mothers, and the clinical features usually appears only after the 20th week of gestation. Now let's see the mild symptoms. The first is slight swelling over the ankles, which causes rising from bed in the morning also. So once the mother is rising from the bed in the morning also, she can see the swelling over the ankles or tightness of the ring on the finger. Early manifestation of the edema is this kind of symptoms. The mother will have tightness of ring on her finger. The swelling may extend to the face, abdominal wall, vulva and even the whole body. Once the swelling starts, it can extend to the face, then moves to the abdomen, vulva, and the mother will experience the edema throughout the body. Now, what are the alarming symptoms? First is headache that can be the occipital or frontal headache due to the increased blood pressure. The mother will have disturbed sleep, sometimes due to the headache. Then diminished urine output that is less than 400 ml per 24 hours. The mother will also have epigastric pain that can be associated with vomiting with a coffee brown in color. Next is a high symptom. She may have blurring or dimness of vision, and sometimes there is chance of complete blindness if there is any spasm of retinal veins. Next, the vision regains within 4 to 6 weeks after the delivery too. So these are the alarming symptoms. If the BP shoots up more, the mother will experience these all symptoms. Till now we have seen the symptoms. Now we are going to see the signs of preeclampsia. First is abnormal weight gain. That can be more than 5 pounds per month or 1 pound per week. So there is a rapid weight gain in the mother. Next is rise of blood pressure, usually abrupt. Diastolic rise first and then the systolic blood pressure will increase. And the third one is edema. There will be visible edema over the ankles on rising from bed is pathological. Sudden and generalized edema indicate the eclampsia also. The next sign is the pulmonary edema due to the accumulation of fluid in the lungs. And the last one is abdominal examination. You can see The scanty liquor or growth retardation of the fetus due to the chronic placental insufficiency. Due to the increased blood pressure, there is more chance of placental insufficiency. That means decreased blood supply to the placenta to the baby, which can result in the growth retardation of the fetus and scanty liquoramine in the womb. Now let's see how the symptoms appear in preeclampsia. First, the mother will have rapid weight gain, and you can see the visible edema or hypertension in the second phase. And once there is an increased BP, the next is the proteinuria, that is a secretion of protein in the urine. So in this systematic manner, you can see the symptoms in the mother. First, there is rapid weight gain, which later you can visibly see the edema, and finally the proteinuria. Moving to the investigation, the first is a urine examination, and that we are going to assess the protein in the urine. That is, proteinuria is the last feature that can be appear in the mother, and it can be the trace, or there may be more chances of protein in the urine, and the urine becomes solid once it gets boiled. Even you can see the epithelial cells and red cells in the urine. And for the protein measurement, we need to take the 24 hours urine of the mother. Second is the ophthalmic examination. As the BP increase in mother, when the BP is increased more than 160 by 110, it can affect the minute nerves of the eye. So it is very necessary to do the ophthalmic examination to find out retinal edema, and even the burst out of retinal veins can result in the blindness in mother. Next is the blood values. As when the kidneys start affected, you can see increased uric acid that can be more than 4.5 gram per dl. The urea level may be increased, so sometimes it can be the normal. The serum creatine level may be also increased more than 1 mg per dl. So these all symptoms you can see once the kidney may be affected due to the increased blood pressure, and the hepatic enzymes may be increased due to the HELLP syndrome, and even the platelet cell will be decreased. So the thrombocytopenia can also be assessed when you are doing the blood examination. Next is the antenatal fetal monitoring. In the previous slides, we have discussed that the increased blood pressure can cause intrauterine growth retardation for the baby. So it is very necessary to assess whether the baby is okay or not. For that, we will be doing clinical examinations, daily fetal tick count, ultrasonography, cardiotocography, and biophysical profile to assess the fetal well-being. Moving to the complication part, in that the first is immediate. Here we are seeing what are the complications the mother will have during the pregnancy itself. The first is eclampsia. Once the preeclampsia is complicated with the seizures or coma, it is known as eclampsia, and there is 2% of chances to convert the preeclampsia to eclampsia. Second is accidental hemorrhage due to the increased blood pressure. It can be the retinal hemorrhage, or the placental veins can be blocked, so there is more chances of accidental hemorrhage. Next is oliguria, which can also result to the anuria. Anuria means no passage of urine, or the passage of urine less than 100 ml of urine in a day. So these can only seen in cases of failure of function of kidneys. Next is the diminution of vision and even blindness due to the retinal damage. And next, preterm labor. The preterm labor is the delivery of baby before the 37 or 36 weeks of gestation. If the mother is experiencing more BP and the doctor find out there is more chances of moving the mother from pre-eclampsia to eclampsia stage, it is necessary to conduct the delivery at the time itself to protect the mother as well as the baby without seeing the gestation. So there is more chances of preterm labor in cases of severe pre-eclampsia cases. And next is the HELLP syndrome, which we have already explained. Next is the complications during labor. So in that also eclampsia can occur. And the second is PPH, that is postpartum hemorrhage. Because of the decreased platelet count, there is more chance of postpartum hemorrhage during the labor. Moving to the complications during cesarean, the first is eclampsia, usually occurs within the 14 hours after the delivery, and shock. It can be due to the increased blood pressure or sometimes due to the PPH, that is postpartum hemorrhage. The mother can move to the shock stage. Next is the sepsis, which due to the increased incidence of induction and operating interference. So due to the increased chance of operating interference, and if you're following any aseptic procedures, there is chances of sepsis. Next is the complications that can occur in the baby due to the preeclampsia. The first and the foremost is the IUD due to the spasm of uteroplacental circulation. If the placental blood vessels are blocked and there is a decreased blood supply to the baby, it can result to intrauterine death. Same as there is more chances of IUGR due to the chronic placental insufficiency. Next is the prematurity due to the spontaneous preterm labor. I have already explained in some cases the doctors need to conduct the delivery without seeing the gestation period to save the mother and the baby. In that case, the mother will be premature. Next is the asphyxia. So asphyxia is a condition in which there is deficient supply of oxygen to the baby. So these are the main complications that can be seen in the baby. Now let's see the remote complications. The first is residual hypertension. The hypertension may persist even after the 6 months after the delivery in 60% of cases. Second, recurrent preeclampsia, and there is 25% chance of recurrence of the preeclampsia in the subsequent pregnancies. Third is chronic renal disease. Once the mother having the preeclampsia, there is more chances or a high incidence of glomerular nephritis for the mother after the delivery. So these are the remote complications that usually seen in the mother after the preeclampsia episode. Moving to the management part, the main objectives of management are to correct or stabilize the altered physiology, to prevent the complications to mother as well as the baby, to prevent the mother from moving from pre-eclampsia to a stage of eclampsia, and finally deliver a healthy baby. So these are the main objectives in the management part. Now let's see the treatment modalities. In the first and the foremost is rest. Keep the patient in left lateral position, or usually give the comfortable position to mother, and we prefer the left lateral position to lessen the vena cava compression so that there will be an increased blood flow through the placenta to the baby, and there is increased venous blood flow which can improve the diuresis and finally reduces the edema in mother. Next, it increases the uterine blood flow, thereby it increases the placenta perfusion and there will be a good blood flow to the baby, which reduces the chance of IUGR. And finally, by giving the proper rest and comfortable position, it will reduce the blood pressure in the mother also. Next is the diet should contain the adequate amount of protein, that is 100 gram. Next, the salt is not restricted and fluid not to be restricted because of the anuria complications. The calorie intake is about 1600 calories per day for a preeclampsia mother. Next is about the sedatives. To cut down the emotional factors, the mother may be very anxious about her status, also may have very anxious and fear regarding the baby. So to give or cut down the emotional factors, we usually give the sedatives like phenobarbital 60 mg or diazepam 5 mg at the bedtime so that she will get enough sleep. Diuretics are not usually given to the mother because it can cause harm to the baby by diminishing the placental perfusion or the placental blood flow to the baby. So usually the diuretics are not preferred to be given to mother. But in some conditions like cardiac failure, pulmonary edema and massive edema in mother, the doctors are forced to give the laxatives, which is the preferable drug, and it is given in the dose of 40 mg orally after the breakfast for 5 days in a week. So in these conditions only like cardiac failure, pulmonary edema or massive edema throughout the body, in this situation only the doctors are compelled to give the diuretics, and the most preferable diuretic is Lasix in the dose of 40 mg for a week. Coming to the antihypertensive usage, the main indications for persistent rise in BP, that is the diastolic blood pressure is more than 110 mmHg associated with proteinuria. Usually the antihypertensive drugs are started to reduce the BP level. The most commonly used antihypertensive drugs are methyl-dopa, labetalol, nifedipine, and hydralazine. Next, we are seeing in hypertensive crisis how these drugs are given. So, in hypertensive case, hypertensive crisis, any of these drugs are given intravenously till the diastolic pressure comes below 110 mmHg. So, the labetalol, that is 200 mg in 200 ml of normal saline at the rate of 20 mg per hour, to be doubled every 30 minutes. Labetalol is the first drug of choice that is given 200 mg in 200 ml of normal saline. Second is hydralazine, that is 5 mg IV bolus, which is followed by the infusion of 25 mg in 200 ml of normal saline. The next drug is nitroglycerin, 5 microgram per minute IV, or you can use the nitroprusside 0.25 to 5 microgram per kg per minute IV. Once the BP is controlled, these drugs are then changed to oral therapy and to be continued. Next is a progress chart. Once you started the treatment, along with that, we need to maintain the progress chart also. The BP you need to measure at least 4 times a day. The state of edema and the daily weight gain or weight loss you need to assess. Next is the fluid intake as well as the urinary output to assess the urine, whether the mother is in the state of oliguria or anuria, that you need to measure the fluid intake as well as the urine output. Then urine examination for protein daily if present, estimate its amount in 24 hours. So in urine examination we need to assess the proteinuria, then the blood for hematocrit, the level of platelet count, to assess the uric acid level, urea level, creatinine level, liver function test also you need to assess once in a week to see the health syndrome. And next is ophthalmic examination to find out the retinal veins. And the last one is the fetal well-being assessment to see if the baby is okay. For that we are doing the ultrasonography usually. So these things we are saying or we are maintaining in a progress chart. Next is the duration of treatment. So it always depends upon the severity of preeclampsia, the duration of pregnancy or the gestation week of the mother, and finally the response of mother towards the treatment. Depending upon the response to treatment, the patients are mainly grouped into three, that is Group A, Group B and Group C. Group A means the pre-eclamptic features are completely subsided. Now the mother is okay, she doesn't have any complaints of preeclampsia, that is Group A. Group means there is partial control of pre-eclamptic features but the BP still remains as high, that is Group B. And the Group C, the mother will have persistently increasing BP to a severe level. So that is considered as Group C. So depending on response to treatment, the patients are classified mainly into three groups, that is Group A, Group B and Group C. In Group A, the patient is advised to attend the antenatal clinic after 1 week of treatment. If the patient is near term, she is kept for few days to complete the 37 weeks of gestation. Thereafter, the decision is taken to terminate the pregnancy or wait for the onset of labor due to the date. So, if the mother has completed 37 weeks and if doesn't have any kind of problem or the BP is under control, the doctor can decide whether the pregnancy should be terminated or they can wait for the onset of labor. Next is Group B. If the pregnancy is beyond 37 weeks completed, the termination is considered without any kind of delay. If the mother is completed 37 weeks, the pregnancy can be terminated without seeing anything. And if it is less than 37 weeks, the expectant treatment is continued up to 34 weeks of gestation. And during that period, there should be careful maternal and fetal well-being during that period. In Group C case, the couple is counselled and the termination is done irrespective of duration of gestation. So in this case, the couple need to be counselled and we will terminate the pregnancy without seeing the gestation period, and it is necessary to give the seizure prophylaxis, and for that the magnesium sulfate regimen is started to prevent any kind of coma or prevent the mother moving towards the eclampsia stage. Steroid therapy is given to the mother if the pregnancy is less than 43 weeks of gestation to prevent the respiratory distress syndrome in baby. Now let's see the methods of termination. First is induction of labor. What are the indications for inducing the labor? In that, the first is aggravation of pre-eclamptic features. We are not able to control the features of pre-eclampsia. That is the first indication. Second, the hypertension persists in mother. Third, acute fulminative preeclampsia, that means there is severe hypertension and we are not able to control by giving the antihypertensive drugs too. Next, the tendency of pregnancy to overrun the expected date. So in this situation, we will induce the labor. Next is the methods for inducing labor. If the cervix is right, that means if the cervix is dilated, cervical induction by low rupture of membranes is usually performed, which is followed by oxytocin infusion to accelerate the process of labor. And if the cervix is not ripe, in that case, first thing we need to give is to give the prostaglandin gel, that is 500 microgram, or the prostaglandin tablets like misoprostol 1 to 2 mg is inserted in the cervix to make the cervix dilated. So once the cervix is dilated or the cervix is ripe, we can do the low rupture of membranes. And during this process also we need to continue the antihypertensive drugs to control the BP. Next is the management during labor. The patient should be in bed. The patient should be in a comfortable position. Liberal sedative should be given in the form of pethidine, that is 75 to 100 mg IM, and to be repeated at the intervals, seeing the condition of the mother. Antihypertensive drugs may be given if the blood pressure becomes high. BP and urine out should be monitored. Careful monitoring of the fetal well-being is mandatory. So these all things we should be maintained or we should observe during the labor. Next, we are seeing the Caesarean sections. So, Caesarean sections are conducted in some situations like when the cervix is unfavorable or the cervix is not dilated for the surgical induction. In that case, the only choice is Caesarean. And in mothers of severe preeclampsia, we are not able to control the BP. In that cases, also the mother will take them for Caesarean section. And in some mothers like elderly primigravida and the mother who having the contracted pelvis or the baby is in malpresentation, in these situations also we will take the mother for the Caesarean section. So in this section we mainly discuss about the preeclampsia, its risk factors, signs and symptoms, complications, and how we can manage the preeclampsia. I hope you all are clear regarding the topic. Thank you for listening.